Welcome, and thank you for joining us today for the fourth webinar in our year-long COVID Commons webinar series, Taking Back Control During COVID-19. I'm Nate Wade, your host for today, and I'm the Senior Director for Strategic Initiatives at ASU's College of Health Solutions. I co-lead our college's COVID-19 Diagnostics Commons initiative with Mara Aspinall, who will be moderating today's event. Mara is a professor of practice at ASU's College of Health Solutions and a diagnostics industry expert who helped found our master's degree in biomedical diagnostics. Mara and I would first like to recognize and thank the Rockefeller Foundation for their generous support of our COVID Commons initiatives. We would also like to thank our partners at the World Economic Forum who have been instrumental in helping us with all aspects of our Workplace Commons initiative. Before introducing our panelists, a few housekeeping items. First, the session is being recorded and it will be posted on our website, asucovidcommons.com. Next, we will have a discussion and Q&A session during the last half of this webinar. Please submit your questions using the Q&A feature. We value your feedback and plan to send a brief survey asking for your input about today's webinar and ideas for future event topics. Finally, we encourage you to get involved in our COVID Commons community. After the webinar, please visit asucovidcommons.com and sign up to receive invitations to future webinars, visit Testing Commons and Workplace Commons, view our T3 Testing Technology Trends blog, or provide an employer case study. Now that housekeeping is behind us, I'll turn it over to Mara, who will introduce our speakers. Mara?
Thank you, Nate, and good morning and hello, everyone, and welcome to today's webinar. We are really excited to have with us three strong and impressive leaders who are known for their decisiveness and their leadership both before and especially now during the pandemic. They are leaders who do not take a simple no for an answer. They've created solutions if they had to optimize the health and well-being of the communities they serve. And what's really interesting today is we're going to be talking about three levels: the local level, and national level, and truly international, because by definition, a pandemic affects all of those. And it's not just about someone else, it's about all of us. Our first speaker is Mayor Kate Gallego. She is the mayor of Phoenix, Arizona, the fifth largest and fastest growing big city in the nation. In November 2020, she was returned to office by the highest number of votes ever cast for a mayoral candidate in Phoenix. Mayor Gallego is also one of the youngest big city mayors in the country and was named a 2020 Young Global Leader by our partner, as Nate described, the World Economic Forum. So it was great that she was recognized by them as well. Mayor Gallego came to the mayor's office with deep experience in business and in government. She worked on economic development for the local utility company, Salt River Projects, as well as serving on the Phoenix City Council. She has been an active business leader and civic leader throughout her career. Mayor Gallego has focused on three policy issues during her time in office: diversifying the Phoenix and even part of the Arizona economy, given how critical Phoenix is, strengthening the infrastructure and investment in the Phoenix area, and working to make Phoenix a leader in sustainability. But clearly, the year 2020 saw a significant addition to that list. She has been dedicated herself and with her team to ensure that our public health is protected by listening and acting consistent with the evolving science and the best practices around COVID-19. We are thrilled to have her with us today. I'm going to leave it at that and introduce each of the speakers right before they speak so you get a sense of them, and we can go right to Mayor Gallego. Welcome.
Wonderful. Well, thank you. Thank you to Mara Aspinall for all you have been doing to help us fight COVID and for convening this. Thank you to Dr. Wade. ASU has been a wonderful partner for the city of Phoenix in combating COVID-19 and making sure we have the right data and information to make good scientific decisions. I have been very lucky to have Dr. Heather Ross as an advisor to my office. Dr. Ross is with ASU and has helped us stay connected to the evolving science and really connect science and public policy, which has been ever more important in this past year. By background, I am a little bit different for a mayor. I hold an environmental degree, undergraduate, so a lot of background in science, chemistry, biology, which at times earlier in my mayoral and public life, there were days when I wished I'd been a lawyer, but during COVID-19, I think has been a good background to have. My college chemistry professor told us that he looked at it and seen the more science, particularly chemistry, that elected officials had, the less likely they were to rise in elected office. So school board members might have a lot of chemistry, and then as you got higher up, you might see even less of it. I have nothing like the background of there are some international leaders who have backgrounds and PhDs in public health, and those countries have been doing quite well. But I hope what background I do have has been helpful in helping Phoenix navigate through this time. I certainly did not expect in my first year in office to issue an executive order, shutting down bars, moving restaurants to takeout, and really trying to put public safety practices in place. As you heard, I have worked in economic development, trying to grow businesses, and that was one of my goals, to develop a smarter Phoenix and stronger economy. But I firmly believe that by putting public health first, we can do that. Even looking at how Phoenix has weathered the storm, we see so many people who have discretion have not yet returned to our economy. So some of the wealthiest folks in our community are not going out to restaurants and participate. But those who are living paycheck to paycheck are and are very vulnerable. We've seen that in Phoenix, if you look at zip code data, our lowest income areas have been the hardest hit. And we've tried to soften the blow and make it easier for this community to navigate COVID-19. Many large cities, most have a public health department. Although ASU has come close, it is not officially our public health department. So in our community, public health is the county function. We at the city have never done things like large scale testing, but we've gotten into that during COVID-19 because our residents needed that. We saw waits of 8-10 hours to get a test. People on my own team had to wait a month to get a result during our July surge. We were the largest city in the country at that time to not get federal surge testing. And so with my city colleagues, we stepped up and really pushed in that area. I originally started by pushing with traditional ways, just reaching out through government to government contact to try to get more federal support, which was unsuccessful. Originally, the federal government said in spring, we just didn't have the caseload for them to support us. By July, when we were leading per capita, we reached out again and didn't get a response actually until I did some Sunday TV, and then the White House called within an hour, and less than a week later, we did get federal surge testing. So it's been interesting to see what tools have worked to try to get resources for my community. I got some interesting feedback from the White House press conference where people said they said I was complaining too much, but I think if you look what's happening in our community now, we need more resources, more great folks telling us what the best public health practices are and talking about how important vaccination is. I've not had the chance to get a vaccine yet, but I am so looking forward to that and trying to use my platform to encourage people to do so. I think we may talk a little bit about this, but right now we are concerned that particularly some of our most vulnerable communities have deep concerns, and some, like our African American community, there's real historical reasons why, very justified, but I hope to work with all of you to get out good public health information, including the importance of vaccination. We have a lot of work to do. The virus is surging in this community, and we're all going to need to partner to get through it. I am excited about my fellow panelists and the amazing expertise we have today, and just want to thank you all for the gift of your time. It's going to be a great conversation.
Thank you, Mayor Gallego. But before, I'm going to ask you just a follow-up question before we go to the next panelist, and we'll make this interactive. How do you deal with the changing information? How do you deal with making policy in an environment which is so rapidly evolving. And even with the best of science, there were answers that we didn't have in March and we had in May, and then sometimes they were frustratingly different in June. How do you deal with that seemingly moving target, particularly in relation to COVID-19?
I try to be very clear about where I am getting my information and what they are saying so that people understand we are responding to the best information we have. For example, early on, we didn't know as much about transmission as we did today, and we had many public policies that were very focused on surfaces. So early on, we were not having people as actively use playgrounds because we didn't know if that was a likely source of transmission. Now that the data is telling us we're more likely to have person-to-person transmission, we've been much more focused on policies around masking and limiting the type of situations where people are not wearing masks. So I know that the public is very frustrated and that they would love to have just complete consistency, and I understand that, but I hope we as policymakers can communicate what are the studies and the pieces of information that have changed, and that is why public policy is evolving. Certainly there's no playbook for COVID-19, and we are trying to make sure we stay on top of the best possible information so that we have policies that make sense and, most importantly, are effective.
Wonderful. Well, that is really helpful. And thank you for your advocacy broadly, and in particular for people in Phoenix and beyond. So we'll come back to that and more of the decisions and challenges and opportunities that you have created in our Q&A. Our next speaker is Rangarajan Sampath. Ranga joined FIND, and for those of you who don't know, FIND is the Foundation for Innovative New Diagnostics. He joined there in 2017 as their Chief Scientific Officer. I will say FIND is the global nonprofit organization accelerating the development, evaluation, and delivery of high quality, affordable diagnostic tests for poverty-related diseases. They are the place to go. They are renowned with a tremendous reputation. FIND has played a role throughout the world in COVID and other epidemics and pandemics in advocating and facilitating this smart use of diagnostics. They are just plain the center of this world. But Ranga himself has been the center of the world around diagnostics, and in particular infectious disease. Prior to his role at FIND, he was the co-founder of IBIS Biosciences and the co-inventor of the groundbreaking Iridica infectious disease diagnostic platform. After the company's acquisition by Abbott, Ranga served as Senior Director of R&D, where he led their efforts in infectious disease diagnostics and was responsible for application development, validation, data analysis, and reporting, as well as the scientific research on the Iridica platform. He has over 200 publications and over 40 patents in infectious disease diagnostics. His research interests include everything infectious disease, pathogen discovery, fevers of unknown origin, tropical diseases, epidemiological surveillance, and biothreat detection. So clearly, he is a great person to talk about what is happening with FIND and around the world with COVID diagnostics. Ranga, over to you.
Thank you, Mara. I mean, I don't know what to say. Maybe just I can turn the time over after that introduction. But no, thank you for your kind words, and also thanks to Nate for organizing and ASU for the invitation. This is a pleasure to be here. I must say I've never shared a podium with a city mayor, so it's a unique opportunity, and I'm really glad. I actually like the title, which actually caught my attention first: the local, country, and sort of the global effort, which truly indicates the nature of this pandemic, right? I mean, this is affecting every one of us, from our homes to cities and countries alike. And it needs a global effort. And as you correctly put it, FIND has been around for 20 years. And our focus has been exclusively diagnostics testing. And we are focused in developing and delivering testing solutions for a number of poverty-related diseases. I mean, think of tuberculosis, malaria, HIV, HCV, and a number of other tropical diseases that we don't even hear of in this country. So it's not new to us, but we've also played a key role in several previous pandemics, whether it was the Ebola in 2014, the MERS, the Zika, and so on. So it's not new to us. We have a large effort in our pandemic preparedness group, in addition to all the other infectious diseases groups as well. And as a global nonprofit, we are based in Geneva, and we work very closely with WHO. We are a collaborating center for WHO. And interestingly, the 13th of January 2020, exactly a year ago, is when we had our first meeting on what to do with this novel respiratory virus that is, where a couple of weeks prior to that, we had emerging information. So it's really an appropriate timing 12 months later here to look at this virus and see how far we have come, what we've been able to achieve. But clearly, there's a long way to go before we get back to what we might call sort of the new normal living. As also Mary said, our focus has been innovation as well as equitable access. Poverty-related diseases means that many of these places don't have the ability to get the same quality technologies that we have so come to expect in our hospitals and clinical labs in the US or UK or other advanced countries. But that shouldn't be the case. I mean, that's really our focus, is we want to have absolutely the highest quality tests, but at an affordable cost, at a way that can be used by the population, the local population that is needed. And that has been our main focus. How do we translate the development and innovation that go on in the rest of the world, but bring them to the low and middle country settings? In COVID, which for the last 12 months, as with everybody else, has been all consuming for us, we have really got the approach of looking at data, looking at all the developments that are going on around the world, and seeing how can we take some or all of them and translate them into solutions that can be deployed in the local economies. Couple of months after the COVID pandemic, FIND, together with Global Fund and a number of other players and countries, unfortunately, with the exception of US, but many of the other European and countries from Middle East and Asia and Africa, convened what is called the Access to COVID Tools, or ACT Accelerator. And we lead the diagnostics pillar for that. And what we have been able to do with that is harness all the innovation, as well as securing access and deploying affordable point-of-care testing solutions that can be used in these countries. And our message has been very clear all along. Testing is a critical tool, and it is essential through all phases of fighting the pandemic. I mean, it's not like you've done testing once and that's the end of it. Testing is critical for the initial pandemic response, to know where the outbreaks are, whether we can actually deploy the test and isolate strategy. But even in the face of vaccines, it's not like testing is no longer needed. In fact, it's all the more needed now, because we want to make sure that the resources and tools that we deploy, where do we do the vaccinations first? How do we ensure that the highest risk targets are being focused on? Testing is equally critical even today. But if you think of some of the challenges that Mayor sort of spoke about, even in Phoenix, which is by no means an LMIC country equivalent, right? I mean, it's just a large city with enough infrastructure, still waiting for a month to get testing done, or getting weeks to get results. It is just not a solution that we knew we could rely on in the LMIC locations. Most of them need infrastructure, the complexity of these testing, the people that are needed, the equipment, and the support, all that is just too complex. So one of ACT priorities was, how do we get innovation such as decentralized, innovative testing that are rapidly deployable in a decentralized manner, meaning you don't have to come to the hospital. How can the test come to you? How can we do this more through easier to use testing that doesn't need large infrastructure, refrigerators, and all those other things? Through that effort, we successfully procured and deployed antigen-based testing, which, as many of you know here, has been a critical armament or tool in our armament. And having these as scalable, affordable, and digitally integrated tests has been crucial to some of the work that we're doing. But now our focus is also looking at it and saying, how do we go beyond healthcare settings? It cannot be just professional testing in hospitals or with clinical labs. How do we get these testing more into a home use setting or workplace use setting? How do we open up the economies with appropriate tools? It's not just about saying everything is good, we can go back, but it's a data-driven approach. How do we ensure that the testing brings some confidence back to people, saying, yes, I'm able to test myself, whether it's on a weekly basis or even more frequently? How can we make these affordable? And when it comes to affordability of daily testing, it's not just about LMICs. You can the same kind of economic factors affect each of us here. No one wants to spend $50 a test for everyday use. It's not affordable. So how do we get to the point? And that's really been our focus. How do we get at really commoditized, low-cost testing accessible? And that's something we're very actively working on with a number of development partners and technology solution providers and so on. And just a last word, as you'll undoubtedly hear through this, and is the impact of the variants. Obviously now, a year later, it's not that the vaccines have come and suddenly everything is just going smooth, it's all smooth sailing. Now there's a twist on the tail. There is a new variant of the COVID virus, a couple of different variants that have sort of emerged and spreading globally. They've taken already, I know I'm sitting in San Diego right now, and it's one of the hot spots for a number of variants that have been detected in the city. So that's another challenge, but we'll deal with it just as we are dealing with other things. I'll pause here and turn it back to Mara and the team, but I'm really looking forward to the discussions.
That is terrific. Well, let me ask you one quick question before we go on to Kelly. For many of these countries, there is not a lot of budget for healthcare, or not nearly as much as needed. How do you balance diagnostics and therapeutics? Putting money into doing the diagnosis, but having enough to be able to treat it. And that's more broad because for COVID-19, treatments are not as plentiful.
Yeah, no, it's a great question. And that's a challenge that diagnostics faces. And I've been in diagnostics for 2.5 decades. And that's been a challenge no matter where you go, whether we were dealing with sepsis in the US or somewhere else. Why should I spend money on testing if I can go straight to treatment, which is why the antimicrobial resistance, for instance, is a big problem, because no one does the right testing. They pump you with antibiotics, and then we have all other challenges. Same challenge happens here. So what our message has been very consistent, very clear. There are 3 pillars to any health response, public health or a clinical health response: testing, treatment, and prevention. Prevention is a vaccine, but without testing, you're essentially shooting in the dark. So we'd rather not have blindfolded approach to how we are treating people. So having the right testing and treating those who need the treatment is really one of the key messages. So resources are limited, and testing, I think, actually provides a much more efficient way of deploying that resource-limited solutions like the vaccines or treatment, and rather than just taking a totally turn the room dark and see where your dart can land. That's not really the approach, and that's been our message consistently all along.
Super, thank you. That's actually a question we ask our students to think about, that balance between diagnostics, therapeutics as part of our biomedical degree program. So with that, we're going to get to our next speaker, Kelly Beaver. And Kelly has a tremendously unique approach that brings not just one person, not just one company, but tens of thousands around the world. Kelly is the managing director of public affairs at Ipsos MORI in the US, known as Ipsos. Ipsos is the global leader in market research that delivers the reliable information and true understanding of society, of markets, and of people. Kelly's team, which is over 200 social science and evaluation professionals, mostly throughout Europe, but they have, as she talked about, offices in the US as well, and she will talk about that, providing robust research and analysis in every aspect of government policy. the work that they do is critical for the kind of decision-making that we're going to be talking about throughout this panel. It is critical to do it with the kind of advice that Kelly and her team put together. Kelly joined Ipsos about 10 years ago in 2011, following her senior roles at PricewaterhouseCoopers or PwC. Kelly has directed multidisciplinary teams in advising local, regional, national, and international government bodies and agencies, particularly nonprofit agencies, on policy design, implementation, and reviews. Kelly was introduced to us also through the World Economic Forum as a key partner for our studies as part of our Rockefeller grant at Arizona State. Kelly is the study director at Ipsos for one of the largest studies in the COVID era, the REACT study, the real-time tracking of COVID-19 pandemic across Europe through mass surveillance via at-home testing on behalf of the UK government. So with that, let me hand it over to you, Kelly. Kelly, you're still on mute.
Infamous phrase in these times, and still will be, I fear, for at least another 6 to 9 months. It's lovely to be with you all, and thank you very much for having me. So as you've already explained, Ipsos is a global company, and I lead the UK government division of that company. And it is a UK, it's an England study that we're talking about when we talk about the REACT programmes. Ipsos MORI in the UK is a household name. We've been delivering social research for government clients and every single part of government for over 50 years. But as you rightly say, we are a global company. And it was actually this time last year that we brought together all of the leaders for all of our government businesses around the world to London. And it was in that meeting that we first started hearing the reports of a global pandemic, a virus that was spreading. And in particular, it had came to the UK. And so this was very much part of the conversations back then. Within a matter of weeks, the UK government was talking about closing down the country in the same way that the Mayor has explained she's unfortunately had to do. And so this was really quite a shock to lots of the British population who had very much seen this as something that was happening elsewhere and not in our back garden. By the 24th of March, our business was affected as well. So staff were sent home, events were cancelled. And what we do is a large national statistics programs, big research programs that rely on face-to-face, door-to-door interviewing. All of those things obviously could not happen in this new low contact era. And so we were very much in a very strange place. Though the dust settled, and with that dust settling, our infrastructure was called upon to support the national effort in the UK. The government put in place what was called a testing strategy. That testing strategy involved not just symptomatic testing, but surveillance testing of the general population in a randomized way so that we could fully understand how the virus was spreading in the community. And this program of surveillance that they were putting together under the testing strategy would be the earliest indicators of the virus spread, but the virus retreat. And the kind of infrastructure that was required for this was absolutely tremendous, because the studies themselves were to look at not just the spread of the virus through antigen testing, but also the antibody response and the proportions of the population who had antibodies at any given time. So what we ended up doing, so there is the REACT program, as you mentioned, Mara. REACT 1 is antigen testing, and we test over 150,000 people in England within a 2-week window. That is our measurement window, where we take a measure of prevalence of the virus in the population using a nasopharyngeal swab. We do this at home, and this is something that is sent to the individual's home. They have instructions, they have videos, they undertake this testing in the comfort of their home. It is picked up by a courier from the home, transported through a cool chain from the point of the courier pickup. It's kept in the fridge by the participant, and then it is taken on to the laboratory and analysed, and the report goes back to not just the UK government at scale, but also our colleagues at Imperial College London, who have a team of epidemiologists there and virologists who do analytics alongside our team for the government, but also to the participant who get their responses in a period of 2 to 3 days. The study was designed to take a random snapshot of the population. They're invited at random to participate. They can do this either through an online or a telephone response. They get sent the study materials, and as I explained, it runs through the cold chain all the way to the laboratory when it's completed. Those results also go to the UK's test and trace team, who will follow up on the positive, those testing positive. But the results also go off to the joint biosecurity team, who hold all of the data for anybody tested in the UK, whether they're tested positive, negative, or whether the tests are inconclusive. If you take a test, that data is all held by the joint biosecurity data team. Those reports are published, they're in the public domain. So that's the antigen study, but there were so many challenges with this when we tried to set it up in April to make sure we had the surveillance in place. There were not enough tests, and this wasn't unique to the UK, this was a worldwide issue. There were not enough tests for surveillance activity to be prioritised over symptomatic testing. There was not enough lab capacity in the UK at that point either. This was pre the government building mega labs to be able to analyse and prioritise surveillance testing. And there was no transportation system which would run a cold chain from an individual's home through to a laboratory. This didn't exist. It existed in a cold chain for products, frozen products, etc., and in small scales for studies which were more located around a common centre. But we didn't want to bring people to a common centre, especially as this was not just symptomatic testing, it was asymptomatic and people who would not have virus as well. So we needed to do it within the home setting. So we moved to we had to put in place solutions against all these challenges, and it really involved a bespoke solution. So the only tests that were being utilised at that time were wet swabs. We moved to dry swabs, which meant we need temperature control, transportation. We couldn't get lab capacity. We brought on board a lab in Munich, and so our tests are sent to Germany for processing overnight. And that meant it also didn't add stress and a strain on the UK lab capacity at that time. We onboarded a courier consortium of 5 to give us a footprint at a national level. And we built the first cold chain from home all the way through at scale for 150,000 homes, right through to the lab process across England. So that's the antigens. We also set up an antibody study. That one, by comparison, was quite straightforward. This tests up to 200,000 people with lateral flow devices for antibodies in their home again. The participants are selected at random. They participate within a study window so we can measure the prevalence of antibodies. They upload the results, pictures of how they've done the test. And again, this is analysed and reported into government on a daily basis. A lot of scepticism in the UK around at-home testing at the beginning, but that has fallen largely away now, as we've not just proven that it's possible. The REACT study is one of the most sensitive tools in being able to identify early when the virus is starting to surge again, and also when it is receding. We've been able to provide significant evidence into government, not just daily, the daily reporting that's done, but also for some of the key decision milestones in the UK, such as at the beginning of September, when it started to uptick again after the reduction in the virus over the summer. We've tested over 2 million people now, which means we have a huge body of evidence to look back on. We identified the rise again in infections in October, so the start of the second surge. And we're currently in field, as I speak to you today, collecting 20 to 30,000 tests a day and sending them to labs for processing. The amount of response that we get now is well above the 150,000, which is fantastic for each round for the anti-gen testing. Longer term, this infrastructure is now being looked at for vaccine surveillance, but also obviously the variant spreading, etc. But beyond all of the testing work that we've managed to support government with, we still do our other research where we look at the impacts of the virus on society more widely. Loneliness, the impact on children, mental health, how effective people perceive the government to be, etc., etc. And we know that the public don't just want medical data used in the recovery period as we start to come out of what has been a very tricky period. They want us to be looking at a wider range of social evidence as well.
Yeah. So can I ask you along those lines, because that is fascinating, and especially the amount of depth that you put into it, and then we'll open to broad questions. So just a quick question now. Have you seen many differences in all your research between the US, the UK, rest of Europe? How How do you compare and what can we learn from that?
Sure. So the scale of the work that's taking place here is quite sizable in the UK, and the amount of investment in surveillance research, as far as I'm aware, is unparalleled. We've seen sizable studies in countries like Spain, where there's been around 70,000 tested antibody surveillance style work, but again, nothing quite of the same scale. And I guess having a government that acts as one body and entity has meant that the UK has put aside significant resources behind this. So there's not a lot that is directly comparable, actually.
Okay, well, I don't know, tough news on that front, but it's great to learn what you're doing. I know that in our US study, our study that we did with you, with 1,100 companies, we found that very many of the systems were the same between the US and Europe, but except contact tracing, there was far less of it here. But let's open this up to questions for our three panelists. And I'd remind people, if you have questions, please put them in the chat, and I will ask the panelists there. But I'm going to start out with, I don't know if it's an easy or tough question, but what have been the unforeseen challenges that you faced as leader during the pandemic? Clearly, some of them that you could have anticipated when we had to close bars and restaurants and the like, but what were some of the unseen challenges and silver linings that you've seen throughout this process? Mayor Gallego, do you want to start?
Absolutely. One that I think is probably very relevant to this group is there's been such distrust of scientific information. Even when I got my flu shot this year, I did it with 4 other mayors and we posted online, and the response was very different than I expected. There were so many people who were posting about things like that I would be very contagious or that Bill Gates would be controlling my mind. The same response when we had our meeting to vote to require masks. The Phoenix City Council did it in a public meeting with testimony. And we heard from people saying that we were doing this to deprive people of oxygen so that we could control their minds. And specifically that I would be controlling people's minds, which I got to tell you, I did not expect that type of response for requiring masks. For me, the trade-offs with masks are so much more in the favor of the policy than if you look at what are the negative sides of masks. And it was just clear the public, by the time we implemented it, it was clear the public health benefits. Communities that had done it had seen rapid declines in transmission, and ASU has put out data showing that we did see rapid declines in transmission in response to masking and a few other policies. But such a strong negative response in that area. So we've tried to learn from that and really have a broader group of people as validators. So early on, we were very focused on scientists and public health professionals, but now people have been giving me advice like I should talk to restaurant blogs and athletes and or just people want to hear from their neighbors about what makes sense and whether their peers, they should get a vaccine, whether they should wear a mask. So I think we've known that there's been eroding confidence in quote experts, but just the distrust of scientific information has been tough.
I very much appreciate that. We have a question, but I want to hear from Bob Cook-Deegan, which is terrific. But I just want to hear quickly, Ranga and Kelly, things that have really surprised you. Well, and the mayor.
Right. And what the mayor started off, the scientific distrust is a key factor, which sort of gnaws at me, being a scientist at heart. But I can also tell you that the number of PhDs in epidemiology, infectious diseases, treatment, vaccines, everybody, WhatsApp and other social media filled with experts that completely, both information and misinformation spreading, right? So this is the time when we come to appreciate that all these social media tools are both a boon and a bane, right? I mean, all kind of information that gets spread through all of that. From our perspective, the main thing was, at the beginning of the pandemic, the first big shocker was how unprepared we all were globally, right? The biggest challenge was as soon as the country started recognizing and started closing border, realize that supply chains get cut off. So you may have a great test, but it cannot go anywhere because you can't import or export things. And we were trying to even do studies across the globe in many different countries across the continents. And we found it took 2 to 3 months to get these tests in because we couldn't get the import permit to get tests and development for evaluations and so on. So a lot of challenges in terms of some of those things which were unanticipated, which hopefully coming out of this, one of the lessons learned would be how do we have a better either security understanding or what we have been focusing on is just distributed manufacturing, having ability to produce these tests globally and regionally. We are actually supporting a couple of, actually three different efforts in global supply chain strengthening, raw materials as well as finished products, right? And that's critical, which became very important. The other big thing, just to quickly add on, is the fact that you couldn't do everything in a lab, which everybody assumes you have a big shiny lab and therefore you can do all the testing. It's just completely nonsense. We need the decentralized testing. We need the home testing. We need the ability to get, for some of these kind of things, which really doesn't need a clinician interaction at that point. The test results can be interpreted by them, but for the testing, if we can get them decentralized, which previously people were very skeptical of, now there's much better understanding that home testing is actually critically needed. I'll stop there, but yeah.
No, and I'll just kind of appreciate that because I have found that even people skeptical of masks and other pieces want to do their own testing. It's why this series is actually called Taking Back Control, because regardless of political or other affiliations, everybody wants control of their own life and not having anyone say what they should do or not do. So Kelly, I'm going to ask you quickly because I will
be quick. The one thing that surprised me from a UK perspective, which is another freedom-loving country, it really is. However, the amount of people who have complied with some of the restrictions that have been put in place that are very, very abnormal for countries like ours and the US, but actually compliance is still very high. We're in wave 3. This is the worst we've seen. And despite the media reports, compliance is still very, very high with a lot of the restrictions in place, which I find surprising. And public willingness to participate in studies to help, again, that public willingness is very high. And that's something I thought would wane over time, but it hasn't. It's been quite stable.
I appreciate your positive piece there because there are clearly outliers, but for most part, people are complying. Bob Cook-Deegan had an interesting question. Here goes. The US surveillance, surveillance in and of itself seems inadequate, just as vaccine distribution seems inadequate, but given our technical resources, this seems fixable. What do you think are the biggest obstacles to developing a sequence-based surveillance to detect new variants? And as all of you know, and I just did a new blog post on this, the challenge of having the new variants and mutations. So maybe Ranga, I start with you here. Is what about our surveillance system? Does it has to be international, or are individual cities going to be doing sequencing on the testing in their cities? How do you think this would work? And Ranga, let's start with you, and Kelly
Sure.
or Mayor, if you'd like to join.
Sure, I can add that. So the first and foremost, it is absolutely a point well worth noting. We actually right after this meeting, I'm at a WHO meeting where we put this data together, which says Europe has about 4 times as much sequencing data today than what US currently has, and of course it dwindles down to a fraction of that when it comes to Africa and so on. So clearly there's a big lag in the recognizing the need for surveillance. Or sequence-based surveillance variants, we're still playing catch up to the testing and rolling out the vaccines. So it seems, even though we have the capacity and there are many large labs that can turn out sequencing and so on, it has somehow been neglected in the whole approach, and I think that's critical. So first, CDC has, and with the collaboration with UK and others, they have a large database, but they're collecting data, but the number of data entering from US is still, less than 25% of what Europe is putting in that. So I think it's a valid question, and it's not that it's easily fixable, but it needs a more dedicated effort in that area.
I appreciate that. Kelly or Mayor Gallego, anything?
Sure.
Issue there?
I can just add to that. So genome sequencing, being quite good at it doesn't help, because then they just call it your virus. It's your variant. So there's now this UK variant because we picked it up, because we do a lot of sequencing in the UK, which is fantastic. We love being known for the variant. But it's now, to be fair, I think Mayor Gallego mentioned it earlier, there is no playbook for COVID-19. And so actually, even the surveillance activity in the UK has not as standard built-in genome sequencing off the back of the surveillance. That is something that has started to happen because we've learned as we've gone along with the introduction of many new variants now, as you mentioned, Ranga. It's really important that we start to be able to sequence every single positive test that comes back, and that is now what's happening. When we send them to Germany, they send them back and they go into our genome sequencing program within a period of time. Couple of days, we get the results back on that to let us know what the actual virus looks like, and whether we're seeing any changes. So again, we're learning as we go too.
And Mara, may I just make one comment, because I think it's important. In fact, that's one of the things we're going to stress in the, we had a large WHO worldwide meeting just 3 days ago on a research forum, and we all agreed that we will not use UK variant, South Africa variant as a name. There is a official nomenclature for all of these. We'll use that, again, to take away part of the challenge which we learned a year ago with the origin and then subsequent sort of impact that this has. So I just wanted to make the point that that's a conscious effort to try and make sure that we go away from naming countries for these variants just because they recognize that early.
That is, it's critical for so many reasons. Mayor Gallego?
First, thank you to Dr. Cook-Deegan for what you've been doing to help us over the last year. We certainly agree we would do better with more data and better, more accurate surveillance. And I've tried to reach out to folks doing the more advanced testing and just ask how we can support them. We also need not just surveillance, but the ability to have ground level action and policies that respond to that. And with our medical system right now being so overtaxed, I worry we don't have the ability to have a nimble response to that data as we get it. We are in such a tough situation right now. So there's a lot to be done.
Yeah, I think that is true. And I'll add from a personal point of view, it makes the vaccine distribution, which I know, Mayor Gallego, you are so focused on as well, more and more critical. If we don't get people vaccinated quickly and this goes longer, I suspect that variants that are there will become more virulent and we will have more variants. So this is not an independent issue, very much related to that. But let me, we just have a few minutes left, and I want to go to a little bit of the positive, which is are there things and systems that, besides Zoom, that we've used during the pandemic that you think will stay with us going forward? And this was asked early in the pandemic, and I think it was too early. I want to know now what you want to stay and what you think should stay and what might stay and you don't want it to stay as we go forward, because hopefully 2021 will be the end of most of the pandemic. So Kelly, do you want to start on this one?
I like your hopefulness. I'm the same. I feel like 2021 is a bit of a waiting room for some semblance of normality to resume in 2022. From a working perspective, yes, you've mentioned Zoom, but I do think, and I think our survey with you showed this as well, that people do anticipate they will be working more from home in their home environments in future, even when things resume to some level of normality. And I think that's something that is actually quite good for us, but not in this higher dosage. So that is something I think people are perceiving 2-3 days from home a week in future and coming together for more collaborative, creative reasons rather than just to sit behind a desk. Those tiers of offices where you're sitting like tiny chickens in chicken coops, I don't think they will survive.
I'm on mute.
Sorry.
Yeah.
Sorry, that's my home phone ringing, which was unexpected. Nobody calls home numbers. So first thing that changed with the system is, nobody knows what these home phones are anymore, but apparently it's spammers do. But in terms of life, as we come to know, the other big thing, these kind of conferences, or meetings and, things where we can bring great minds together and have, tackle challenges, it's been a boon that many of us have been advocating for virtual meetings, and finally it's become the normal. Now we can actually conduct full day or even 3-day meetings and so on very effectively. And I think that's a great thing. And I think part of learning to work from home and coping with all the challenges like the phone ringing, but in reality is that we can bring efficiency into our lives in a way that we were losing control of. In a way, the pandemic is sort of resetting some of those things that we also got used to. And I can be proud of the frequent flyer mileage I have, but that's, the toll on my body, right? Now I can say, okay, you know what? There's a different way of doing it, and it can be effective. It's not just a stopgap, but it's actually an effective way of dealing with. I think our work life hopefully will improve, but normalcy to life, I think it's going to be, and I'm hopeful as everyone else is, that we'll see better, but it's January, and I don't want to make any predictions right now.
Yeah, I appreciate that, but at least you agree on the cautious optimism that 2020 will be much more normal.
I'm very optimistic, and I think there are better tools we have in our toolbox now. I think that's the first thing, and science hopefully will rescue with appropriate policy in place to get out of this mess.
Well said. Mayor Gallego, let me give you the last word on this one.
Wonderful. We at the city have been trying to talk about social determinants of health, as have many of you at ASU and other institutions, but I think it's become forefront for so many of us right now. We've seen who has been impacted most by COVID-19 and the complex situations in which this all began. Sort of any disparities have been magnified, and I hope that consciousness is something that will stay with us. I've been very enthusiastic about the growth of telehealth, which is important for people who have transportation challenges, who live in rural settings or other places where they might not have great access to healthcare. I was just speaking with some folks at one of our providers for people living with HIV and AIDS, and they said they've actually had a dramatic growth in people being able to complete their appointments with their provider. So because they can now so easily just do it on their phone, people are showing up much more often and getting better outcomes. I would also say, I feel so much more connected to mayors globally. Before COVID, we talked with mayors in the United States, but because particularly in Asia, there were some mayors who had just very effective early public health responses and were able to implement, for example, great testing programs. We are now speaking more globally. My first interaction with mayors globally was actually through C40, which is a organization of mayors to fight climate change, but we use that platform to learn from some Korean and Chinese mayors in particular. And that was so helpful to me. And I think that's a benefit that I hope will continue, as well as these more flexible working environments. I'm a mom of a 4-year-old, and so I know it's a challenge to be a working parent, but I like the fact that we're doing now more remotely. And as you just heard, people don't hop on a plane quite as easily. We'd have a flood in Phoenix and I'd hop on a plane to talk to the White House about a presidential disaster declaration. And I think Zoom would be just fine.
Yeah.
So I hope some of that stays with us as well. It's been nice to see the air quality improvements and people getting more family time.
I love that. And that came out just yesterday on doing that and balancing that family time with hopefully the kids going back to school. So we get a few hours a day without the kids in the house. So a very last question from Dean Deborah Hellitzer, who has been another tremendously strong leader at ASU and beyond, the Dean of the College of Health Solutions. So quick fire, and this will be our last question. And then Nate, I'll hand it over to you for the summary. But Dean Hellitzer asks, Kelly mentioned that the UK is sending their samples to Germany to be tested for variants, as well as doing sequencing within the UK. Would you recommend that the US create a centralized center for surveillance, or is regional and state surveillance testing preferable? So quick fire answers. Kelly, I'll go in the same order. Kelly, Ranja, and Mayor Gallego.
Very quickly, just we don't send all our samples to Germany. The vast majority of tests are processed in the UK. Surveillance wise, some of them are sent to Germany just so it keeps capacity for symptomatic testing in the UK. But there is a center where all the surveillance activity goes together to be triangulated, which is incredibly important because it's coming from so many different sources. And if you add in things like workplace testing, that all needs to be brought into a central place so that you can make decision making and have the evidence that you need to do that. So I'll leave it there.
Perfect. Thank you, Ranga.
Our vision for surveillance has always been a bit more decentralized. So having more regional centers, again, we talk about countries where there's not enough capacity and so on. So to be able to do that, but be digitally connected. So having centralized way of monitoring all of this, but doesn't have to, because transportation, many of the countries that we deal with is just impossible. We cannot get a sample across just as easily as you could from UK to Germany, or even, Phoenix to San Diego or some other place. So our approach is, how can we build the capacity in sort of regional focus, but have more centralized way of data sharing and data dissemination that can enable response.
So potentially decentralized labs, centralized information.
Exactly.
So with that, Mayor Gallego?
I would say the US is so broad that we need that local and regional testing knowledge.
Exactly.
In the city of Phoenix, we've looked at zip code data and made decisions based on that. So I think local intelligence is very important because we've seen the virus has spread very differently in different areas.
Yeah, that's a very good point. So with that, let me say, I'll hand it over to Nate, but just a personal thank you. This was a great wide-ranging conversation. You come from very different fields, but really appreciate you coming together today for ASU and for our audience. Over to you, Nate.
Great. Well, that's all we have time for today. Thank you again to our panelists, and thank you all for attending. And we hope you enjoyed the conversation and took away some new ideas. We value your feedback and plan to send a brief survey asking for your input about today's webinar, and we would greatly appreciate your participation. We encourage you to visit asucovidcommons.com to learn about future webinars, view today's webinar recording, read our report, Facing Uncertainty, the Challenges of COVID-19 in the Workplace, and get the most current data on COVID tests at testingcommons.com. Please save the date for our next webinar on Thursday, February 25th at 9 a.m., where we will be discussing K-12 education and reopening our schools. Once again, thank you for joining us today, and stay safe. Thank you.
Thank you all.